Update from the U.S. Preventive Services Task Force. My name is Jessica Reed. I am the Clinical Quality Manager for the Maine Medical Association Center for Quality Improvement, and I will be your host today. My colleague, Mary Milam, will handle the technical aspects of Zoom, and we are so excited to have our speakers here today. Dr. Michael Berry, he is the Director of the Informed Medical Decisions Program within the Health Decision Sciences Center at Massachusetts General Hospital. He is also the Vice Chair for the U.S. Preventative Services Task Force. And Barbara Wiggin, she's the Manager of Oncology Services for Radiation Oncology and Cancer Registry for Maine General Medical Center. So again, welcome. Next slide. I have a few housekeeping slides, and of course would like to very graciously thank our funders, without which this would not be possible. I'd like to thank the Bristol Myers Squibb Foundation, the Maine Cancer Foundation, the Maine Economic Improvement Fund, and Anthem Blue Cross Blue Shield. We have a few, again, housekeeping notes. So you are in listen only mode. Please use the chat feature to ask questions or make comments during the presentation. The video size, screen, and location is adjustable. You just have to click at the top corner of the boxes and drag that to open that up. If you're by phone or with others on the same computer, it is important for you to enter your information into the chat window, or you can send your name and email to marymilam@mainemed.com. We are providing CME for today, and we have a disclosure that today's speakers do not have any relevant financial relationships with the manufacturers of any commercial product or products and or provider of commercial services discussed in this CME activity. CME will be available for participants who have signed into the live webinar. And again, if there are multiple people at one computer, please type your name and email addresses into the chat box for our attendance records and to get your CEUs. We do not have separate nursing CEUs, but you can get a CME certificate. A link to the online evaluation we put in the chat box near the end of the webinar, and you can request CME through this online evaluation. We will also send out a follow-up email to all attendees with the online evaluation link, and we ask that you please complete the evaluation via SurveyMonkey within 2 weeks. We will be sending out the slide deck to all attendees as well. For the CME documentation process, a really nice feature is you'll be able to immediately download your CME certificate on the last page of the evaluation. And again, if you have any difficulty, questions, or problems downloading the certificate, please contact Mary Milam at milam@mainemed.com. Next slide, please. Today's learning objectives, we're going to describe the process by which the USPSTF reviews the evidence and makes a recommendation on a clinical topic. We're going to briefly explain the evidence that led to the USPSTF to the recent change in the eligibility criteria for lung cancer screening. We're going to define shared decision-making and explain why it is recommended as part of lung cancer screening. And we're going to look at the rules regarding timing of insurance coverage changes in response to the new USPSTF recommendations. So again, I'd like to welcome you all to Lung Cancer Screening 2021, update from the U.S. Preventative Services Task Force. I'd like to talk real briefly about our wonderful speakers that we have today. Again, Dr. Michael Berry, he's the Director of Informed Medical Decisions Program within the Health Decision Sciences Center at Massachusetts General Hospital. He's also a professor of medicine at Harvard Medical School and a physician at Massachusetts General Hospital. Dr. Berry joined the U.S. Preventative Services Task Force in January 2017 and now serves as its vice chair. He is past president of the Society for Medical Decision Making and the Society of General Internal Medicine and a master of the American College of Physicians. He previously served as chief of the General Medicine Unit at Massachusetts General Hospital. He also served as director of the MGH Primary Care Program. He received the Department of Medicine's inaugural Alfred Cranes Teaching Award. Dr. Berry continues to practice adult primary care at Massachusetts General Hospital. His research interests include defining the outcomes of different strategies for the evaluation and treatment of prostate disease, decision analysis, health status measurement, clinical quality improvement, and the use of decision aids to facilitate patient participation in decision-making. He has led prominent research studies, including the Patient Outcome Research Team for Prostatic Diseases, as well as many other clinical trials and patient outcome studies. His work in prostate outcomes research earned Article of the Year honors from the Association for Health Services Research. He was also the recipient of the James D. Bruce Award for Distinguished Contributions in Preventive Medicine from the American College of Physicians in 2020. So it's great to have you, Dr. Berry. We also have with us today Barbara Wiggin. She's the Manager of Oncology Services, Radiation Oncology for Cancer Registry for Maine General Medical Center. Barbara has worked in healthcare for over 17 years, managing multiple departments and developing programs with a focus on improving patient access, quality of care, and reimbursement for radiology services. And we are very excited to have her today with her expertise around the reimbursement component for lung cancer screening. So thank you so much, Barbara, for being with us today as well. So at this point, I am happy to turn the presentation over to you, Dr. Berry.
Great. Seem to be going backward.
It looks like you have it now, Dr. Berry. You have control of this.
Okay.
In the bottom left-hand corner. There,
Okay.
yep. There you go.
Okay, I'll keep this cursor in the same place. Thanks for the kind introduction. The only way you can amass all those titles and things is to be kind of old. So that's the skinny and takeaway from the introduction. But I appreciate the invitation, and I'll fill you in on new recommendation from the U.S. Preventive Services Task Force on Lung Cancer Screening, hot off the presses. So I've got a talk in two parts. I'll talk a little bit about the task force itself and how it makes a recommendation for something like lung cancer screening. Then we'll do a deep dive into the lung cancer recommendation. So the background, the task force works to improve the health of people nationwide by making evidence-based recommendations on effective ways to prevent disease and prolong life. We hope to help healthcare providers and patients work together to make informed decisions about preventive care, and we provide preventive guidance on more than 80 health conditions and diseases for people of all ages. Our recommendations apply specifically to people without signs or symptoms of a specific disease or condition. If folks have symptoms, then that's diagnosis rather than prevention, and that's not our bailiwick. We really focus on preventive services offered in primary care or referable from a primary care provider, and that's why our orientation and our members come from primary care. And we really address three types of preventive services: screenings, as with lung cancer that we'll talk about today, but also behavioral counseling and preventive medications. A little task force history. The first task force was convened by the Public Health Service back in 1984. That was the Reagan administration. Sometimes people in Congress think we're a creation of the ACA, and there is a connection to the ACA, but we go back much longer than that. In 1989, a first edition of Guide to Clinical Preventive Services was published, and then a second task force was convened in 1990. And this was meant to be an ongoing task force, and we've been together since then making recommendations. The second edition Guide to Clinical Preventive Services, pictured on the right of the slide, and I expect familiar to many of you who've been in practice for as long as I have, came out in 1995. In 1998, the support responsibilities transferred from the Public Health Services to the Agency for Healthcare Research and Quality, and they're a terrific partner in terms of supporting the task force work. And then in 2010, the Affordable Care Act required private insurers, with few exceptions, to cover the task force A and B recommendations, of which there are currently about 50, without cost sharing. We're going to get to that in Barbara's section of the talk as well. It's interesting to note that the ACA doesn't require either Medicare or Medicaid to cover those services, so they make their own decisions, often following suit, but often in different ways, as we'll get to. There we go. So we're in an independent panel of non-federal experts in prevention, evidence-based medicine, and the 16 of us are volunteers and represent all disciplines of primary care defined broadly, including family medicine, general internal medicine, nursing, OBGYN, pediatrics, and behavioral medicine. We have a chair and 2 vice chairs. We serve a 4-year term, and then as I'm stepping into the role of vice chair, I'll be a vice chair for another year, and then chair, there's another 3-year term for the leadership team. We're appointed by the HRQ director with guidance from the chairs, and we are very rigorous about potential conflicts of interest, and you can look at our member websites to see our disclosures. So how do we develop a recommendation like lung cancer screening? Well, first there's a topic nomination process, and anyone can go to our website and recommend a topic as long as it fills those definitions of preventive services in asymptomatic individuals. We consider all those, so I'd encourage you, if there's something you think we should be addressing and we're not, to nominate topics. Once we select a topic, or if we're updating an existing topic, which we do every 5 years or so, we develop a draft research plan, and I'll show you a little bit about the skeleton of those. That actually gets posted for public comment for a month before it gets finalized. And I'll make the point here that the task force is very transparent, and we post our recommendations in the making at multiple points, and anyone can comment, and many often do. Once we have a research plan finalized, an evidence-based practice center funded by HRQ does the systematic review that provides the evidence on which the recommendation is based. The evidence review is presented to us in draft and is also posted for public comment, along with a draft recommendation statement. Again, 4 weeks of comments, we usually get a ton, and then the final evidence review and final recommendation statement are posted on the website, and these days published in JAMA. This is an example of the analytic framework we use for a screening test. I picked screening for atrial fibrillation here. And can you all see my little cursor? Barbara's nodding yes. So basically we start with a population on the left here, asymptomatic older adults. And we often have 2 pathways by which screening or behavioral counseling or preventive medicines can affect the patient outcomes that are most important to people. Go back. Oh dear. Okay, I've got like, Mary, can I give control back to you?
Sure. Let me just.
And I'll just call for the next slide so we don't annoy the audience overly. And if we could go back a couple of slides, that would be great. Okay, right there. So you see at the top, there's a big 1 in a circle. So each of our steps in the analytic framework is linked to a key question. And question 1 is what we call the direct evidence pathway. And if you look down below, it says, does screening for AF improve health outcomes? So these would be basically randomized trials to test whether screening for AF reduces all-cause mortality, stroke-related morbidity, quality of life. And we really like to base our recommendations on what we'd call key question 1 or KQ1 evidence, the direct pathway. Sometimes we need to follow the middle route, and we might ask if screening improves the diagnosis of atrial fibrillation. We'd look at the harms of screening, and the task force always tries to be systematic about harms as well as benefits? And do people who have a diagnosis of atrial fibrillation treated with anticoagulation in this context have improvements in those health outcomes at the right? I will say that it's been a challenge to use the indirect pathway for atrial fibrillation in the era of the Apple Watch and other types of long-term monitoring outside the office, in that the spectrum of atrial fibrillation diagnosed by long-term monitoring may be different than the atrial fibrillation we often treat and have evidence for in the anticoagulation trials. So the lesson here is analytic framework, key questions. This is what triggers our review. And there's a systematic review for each of the key questions. Next slide, please. So it's basically that evidence that gets us to recommendations. I'll show you on the next slide exactly how we get there from the evidence. But basically an A or a B recommendation is a recommendation for clinicians and their patients to do it. A is just a little bit higher level of evidence, and I'll show you the difference. A C recommendation is a recommendation to selectively offer or provide the service to individual patients based on professional judgment and patient preferences. And the D recommendation is our recommendation against a particular intervention. If we don't find enough evidence in our systematic review, we acknowledge that with an I rating, insufficient evidence. We do not, as some guidelines groups do, fill in when the evidence is inadequate, expert opinion to make a decision. We'll reflect on what the I statement means for clinicians, but we don't go further. We stop when the evidence stops. Next slide. So there are really two things that drive those letter recommendations. One is our estimate of the magnitude of net benefit, that's benefit versus harms for intervention, and how certain we are based on both the evidence-based practice centers and our evaluation of the strength of the evidence. So to get an A, you need high certainty that the net benefit is substantial. Similarly, if we have moderate or high certainty that the benefit is zero negative, it's a D, and you can see that a B can be either high certainty of a moderate benefit, moderate certainty of a substantial or moderate benefit, and a C involves high or moderate certainty of a small benefit. If our certainty is low based on the evidence, again, that leads to an I recommendation. Next slide. Okay. Let's dive into screening for lung cancer and what's new there. Next slide. So I don't need to tell this group how important lung cancer is. Again, about 135,000 deaths last year. And the most important risk factor, as you know, is smoking. It accounts for about 90% of all lung cancer cases, with a relative risk of lung cancer approximately 20-fold higher in smokers compared to non-smokers. Age is also an important risk factor. This is the epidemiology of lung cancer presents both an opportunity and a challenge. The opportunity is we can really focus screening on people who are at highest risk compared to many of our recommendations, say colorectal cancer screening, where it's sort of screen everyone above a certain age. But the challenge is we need to have good documentation of smoking behavior, and I'll get to that. Next slide. So why screen? Lung cancer, when diagnosed with symptoms, has an overall poor prognosis, overall survival at 5 years about 20%. Early stage lung cancer has a better prognosis and more amenable to treatment. Those in the audience who are familiar with lead time bias know that better 5-year survival is necessary but not sufficient to know whether there's a benefit from lung cancer screening. Next slide. Okay, so our new recommendation is that adults age 50 to 80 who have a 20-pack year smoking history and currently smoke or have quit within the past 15 years should be screened with annual low-dose computed tomography, and that's a B recommendation. Again, the recommendation to do it. Next slide. So how has that changed from our 2013 recommendation? Back in 2013, we recommended that adults age 55 to 80 with a 30-pack year smoking history, current smokers or quit within the last 15 years, should be screened. And we affectionately call that the A, that's annual, 55, the starting age, 80, the stopping age, 30-pack years, and 15 years since quit. And I'll use that parlance throughout the talk. Now, again, the change here is 50 to 80, so dropping the starting age from 55 to 50, dropping the pack year threshold from 30 to 20, but keeping the 15 years since quit. Next slide. So let's dive into the evidence of why that changed. First, just a little bit about our review. The systematic review covered the accuracy, benefits, and harms of screening for lung cancer. We looked at whether there were variations by subgroup, including race and ethnicity. We looked at the number and frequency of low-dose CT scans that would be required, and the protocols for lung nodule classification that might help improve specificity without too much sacrifice in sensitivity in our screening. We also commissioned a set of modeling studies from a group called the CISNET network supported by NCI. The beautiful thing about CISNET is there are actually 4 groups who have different structural models that look at the harms and benefits of screening. And we can feel more confident when all the models give us the same answer. Things that we can address in modeling studies that you just can't do a clinical trial for to answer every question, are things like the optimal age to begin and end screening, the optimal screening interval, and the relevant benefits and harms of different screening strategies other than the exact ones that were used in the randomized trials. Next slide. So our analytic framework here is more tortuous, and I'm not going to belabor it other than to say we're fortunate that we've got that KQ1 evidence, direct evidence from now 2 randomized trials that get us from screening adults at increased risk to a reduction in all cause in some cases, but particularly lung cancer mortality. So we're not going to have to belabor the indirect pathway, but we do look at the harms of screening, workup, and surveillance because the false positive rate is pretty high in terms of nodules discovered, and then the harms of treatment have to be considered as well. Next slide. So let's look at the direct evidence. Again, the first trial, as you all know, was the National Lung Screening Trial done here in the United States involving about 53,000 people. They were randomized to annual lung cancer screening with low-dose CT for 3 years and followed up in the initial report for about 6.5 years. At 6.5 years, there was a relative risk reduction of 20%, statistically significant. There was also in this first publication a reduce in all-cause mortality. That's really rare for screening tests. Was not seen actually in later follow-up, but I think it's not necessary to recommend a screening test. The reduction in lung cancer mortality is enough. Now, those of you know about lying with statistics know that relative risk reductions are the best way to do it. 20% reduction sounds a lot, but the absolute risk reduction is 62 fewer lung cancer cases per 100,000 person years. It can be hard to wrap your head around that. Just think that if 1,000 people eligible for an LST were screened and followed for 10 years, we'd get about 6 fewer cases of lung cancer mortality. Now, that was the trial available in our 2013 recommendation, and that's why the eligibility starting at age 55, the 30-pack years were adopted because those were the NLST criteria. But there's a new kid on the block just published called the Nelson trial. This was done in Northern Europe, about 16,000 participants, so smaller than NLST. And it turns out that their estimate of the relative benefit of lung cancer screening, which they did a little bit differently, as I'll get to in a minute, was about a 25% reduction over 10 years of follow-up. Their absolute risk reduction was 80 fewer lung cancer deaths per 100,000 person years, or 8 fewer deaths if 1,000 people are screened and followed for 10 years. Now, it's misleading to compare the 8 versus the 6 to NLST because the absolute risk reduction will depend on the follow-up, and Nelson had longer follow-up. The takeaway message here is that the absolute risk reductions are about the same. Nelson screened a little bit differently. Folks got a first CAT scan at baseline, then a repeat at 1 year, then a repeat 2 years later, and then a repeat 2.5 years later. So they were spread out over time and still found about the same absolute risk reduction. Our CISNET modeling studies really showed that annual screening with low-dose CT provides greater benefit in lung cancer mortality and life years gained with annual screening compared to every other year screening. And I'll get to some of that modeling in a minute. Next slide, please. So those are the trials. It's worth commenting that the Nelson trial enrolled younger participants. You could be 50 to enter the Nelson trial as opposed to 55 in NLST, and folks had a lighter smoking history. In fact, about a quarter of the Nelson participants were younger than age 55, and a quarter had lighter smoking histories down below 30 pack years. So we've now got some direct evidence for the younger folks, 50 to 55, and the lighter smokers, 20 to 30 pack years. We found that our new recommendation, screening folks annually starting at age 50, going to age 80, I'll give some caveats on when to stop, and a 20-year smoking, 20-pack year smoking history, 15 years since quit or current smokers, would reduce lung cancer mortality by about 13% and avert about 500 lung cancer deaths and give us about 7,000 life years gained compared to our previous recommendation, the 55 starting age and 30 pack years. And I'll go into this in a little more detail in just a sec. Next slide, please. Okay, now, again, we need to consider harms as well as benefits, and there are plenty of harms to think about with lung cancer screening. The main one are false positive results in terms of lung nodules that lead to unnecessary tests and occasionally invasive procedures. Somewhere between a quarter and a third of people in the two trials had false positive results, and they were defined a little bit differently. Nelson called nodules that you saw but didn't label as cancer yet as indeterminate, and then if they turned out to be negative on serial scanning, didn't count them as false positives, where the NLST did from the perspective of sitting across a table telling a patient that, boy, there's something on their chest CT that could be cancer, we've got to follow it. That may generate some anxiety, and frankly, from my perspective, should be considered a false positive result. In addition to nodules that we need to follow up on, most of which will turn out to be benign, there are incidental findings outside the lung, and I suspect all the primary care clinicians here have been bedeviled by thyroid nodules and liver nodules that turn up when the focus is the lung. Maybe there's some benefit to that, maybe there's not. Short-term increases in distress due to those indeterminate results, overdiagnosis, and radiation exposure. A little bit deeper dive here. In the trials, among all patients screened, the percentage of people who had a needle biopsy for a false positive result was really 5% or 0.5% or less, with complication rates much lower from those needle biopsies. Surgical procedures for false positive results were reported in really less than 1% of folks. There's been a lot of debate about whether the conservative approach to lung nodules seen in the trials can be maintained as lung cancer screening gets diffused into community settings, but the early evidence would suggest that it can be. Screen-related incidental findings ranging from coronary calcifications to thyroid nodules have really varied, not only in the trials, but in other cohort studies of screening, ranging from about 5 to 40%. And it's not clear, again, how many of those are beneficial incidental findings versus things that just add cost and potentially morbidity. Overdiagnosis, we've estimated in our models, whether we use our 2013 or current recommendations, about 6%, fairly low. In other words, lung cancer is not destined to cause future morbidity and mortality. Someone may be destined to die being hit by a bus in 5 years, in which case lung cancer may not be important. But the 6% pales in comparison to, say, prostate cancer screening, where overdiagnosis is way higher. Radiation exposure with one low-dose CT scan is less than the average annual background radiation in the US, but remember, we're recommending screening from 50 to 80 with people getting an average of 18 scans. So that radiation exposure will add up, and we did include in our modeling the potential for cancers induced by our repeated low-dose CT scans. And I'll say in follow-up, some of the low-dose CT scans become full-dose CT scans as people are being followed. Next slide, please. Okay, so let me walk through this a little bit. So this is the results of our SysNet modeling, looking at those different strategies, and you can see our nomenclature pointing to the various dots. On the x-axis are the number of CAT scans required per 1,000 population. And on the y-axis are the number of deaths avoided per 100,000 population. Now, in doing this, the 100,000 population I'm talking about is just taking a group of people at age 45 who are represent the diversity of the US population, including their smoking histories. So my denominator here includes the non-smokers, the ex-smokers who aren't eligible, and the people who are eligible. That's important because as we change the thresholds for screening, we could change the denominator, making it hard to compare. So we're using the same denominator here of a segment of the US population. It's important to remember includes the smokers and non-smokers. Now, if you look right about in the middle of the screen, the line that you see there is what's called the efficiency frontier. So strategies at or near the efficiency frontier look good in terms of the trade-off between the number of CAT scans you have to do and the number of deaths you avoid. We had an a priori definition for how close to that efficiency frontier was close enough to be statistically indistinguishable. And basically the darker circles, the ones that aren't faded out, are the strategies that made the efficiency frontier. There's a red diamond sort of just to the left of the middle of the screen. That's our old recommendation, the A55 80 30 15 recommendation. And what you can see is by adding more CAT scans, going further to the right on the x-axis, you can prevent more lung cancer deaths. The challenge here is there's not a clear flat of the curve, right, where there's no benefit from doing more and more CAT scans, and probably there'd be a little benefit if people just lived in the scanner, you know, had their meals brought in by Uber, but you know, what's reasonable? We ultimately elected to go with the A50 80 20 15 criteria, which is a little bit below the efficiency frontier, but not definitely so. You can argue that that's a somewhat arbitrary choice. We certainly didn't want to go farther to the left of our old recommendation and avoid fewer deaths. We wanted to avoid more deaths at a reasonable number of CAT scans, which to some extent will dictate the radiation exposure and harm. Let me drill down in the next slide. Okay, so looking at that 100,000 population, including the smokers and non-smokers, our old recommendation, A55, 80, 30, 15, about 14% of the folks in that US segment of the US population would be eligible for screening, and they get about 225,000 screens. That'd be an average of about 17 CTs per person screened, and we'd avoid 381 deaths in that cohort, about a 10% reduction. If you go down to the number of screens, the number needed to screen, the number of CAT scans, and then the number of people you need to screen to prevent a lung cancer death is about 36. As screening goes, that's not a bad deal. If we then take the first step in the middle column and drop the pack year criteria to 20, but still start at age 55, 20% of the population is now eligible. So we're bringing in the lighter smokers. I'll talk about the implications. We're doing more CT scans, 330,000. It's about the same number per person, it turns out, and we'd prevent about 469 deaths. And if we take our last step, which is where we wound up with a starting age of 50 and the 20 pack year criteria, about 21.5% of eligible, we're up over 400,000 CT scans. So we're multiplying the CT scans here, about 19 per person, but we avert 503 deaths. We thought that this was a reasonable place to stop after a lot of debate and external input. We could have had greater benefit, but it would have required a lot more CT scans to do so. So that's where we wound up, and that's the modeling explanation of why. Next slide, please. Okay, so I need to reflect on the impact of that change in criteria on the health equities in screening. So it turns out Black people who smoke have a higher risk of lung cancer compared to white people. And that risk is more apparent at lower levels of smoking intensity, at least as quantified by pack years. The 50, 80, 20, 15 program leads to a relative increase in the percentage of people eligible for screening by about 86% overall, 77% in non-Hispanic whites, and 105% in non-Hispanic Blacks compared to the old 2013 recommendation. So hopefully by bringing in the lighter smokers at a younger age, we're helping reduce the inequity that may have been built into the prior recommendation. And we're going to need more research to sort that out over time. Next slide. All right, a few comments in closing here. The task force recommends discontinuing screening if a person develops a health problem that substantially limits life expectancy or the ability or willingness to have curative surgery, as well as if they get beyond the 15-year window of quitting. The most important thing to emphasize here is, as effectively as we think lung cancer screening is, smoking cessation is the most important intervention to prevent lung cancer, and screening should be viewed as an adjunct to tobacco cessation programs. People who are enrolled in screening, who are current smokers, should receive smoking cessation interventions, and those who have quit should be encouraged to stay quit. Shared decision-making is when clinicians and patients work together to make a better health decision, where the clinician communicates the harms and benefits to the patient, and the patient communicates their values and preferences back to the clinician. As I say, there are substantial harms, and for someone who thinks that the 25 to 35% risk of finding a nodule that might be cancer and may not be sorted out for years, if that's a really morbid thought to them, screening may not be for them. So shared decision-making is important, even though on a population basis, we make the B recommendation. And standardization of screening and follow-up of abnormal findings is important. I talked about that as we move from academic centers to community centers. Just like there's a BI-RADS for mammography, there's a lung-RADS system that may reduce false positive results, but may actually decrease sensitivity as well. So more research is needed there. Last slide. One more. Okay, so, oh, I'm sorry, before that? Thank you. So this is what you guys are doing, which is implementation. So I walked into my practice leader's office, a very smart woman, and our health system, formerly Partners, now MGB, recently spent $1.2 billion on an electronic medical record system. With all that computer power behind this monitor, what she's done is she scotch taped our old recommendation onto the bottom of her monitor, along with names of social workers she worked with, et cetera. So the unfortunate thing is we think even by our old recommendations, only about 15% of people have been screened. How do we keep it simple? How do we recognize the people who are needed for lung cancer screening? Obviously, accurate smoking histories is key. Many people have urged us to use more complicated risk prediction models that you can't tape to a computer to remember, where you have to go in and actually input multiple factors beyond age and pack years and when you quit. And those may be important additions, but we want to be sure that those don't create barriers to implementation. So we've kept it simple, and I've promised to give her a new strip to tape with our new recommendation down at the bottom there. So with that, I'll skip to the last slide and just say our website for the task force is there, and we'll, I think, do questions at the end. But I'll turn things over to my colleague Barbara to talk about another practical issue with implementation. Who's going to pay for all these CT scans and when?
And Barbara, why don't I just continue sharing the slides and you can just tell me next slide.
I think that sounds great, Mary.
Okay. There we go.
So thank you, Dr. Berry. You had the perfect leadway into the next portion of the topic is how do we now manage this? So I think everybody probably on the call saw the great announcement, and I think everybody who's been had their heart in working on this is really excited about it. But then next steps is how do we manage it? So you can go to the next slide. So just like Dr. Berry had mentioned, the Affordable Care Act does require that private insurances cover all preventative care tasks that fall into the task category B, which clearly this falls into. The tough part about that, you can go to the next slide, is that they do have some time to cover this. So it's not immediate. They do have about a year, and it does look like there's some leeway. We're predicting that by March of 2023, all private insurances should have this covered. So that's kind of a long timeline, seeing that we're in 2021. So hold on to your horses and let's watch what private insurances do. There are many people that are advocating for this recommendation to be covered more quickly, but we don't have any control over how the private insurances will cover this. Now, from an administrative standpoint, the other thing that we have to be careful of, and remember that the recommendation for lung screening by the task force came out in 2013, but Medicare, as we all know, didn't start to cover it until 2015, which is when many of us were able to jump on the bandwagon and try to figure out all the loopholes that all the things that we had to jump through to get CMS coverage. So watch our CMS coverage, because that does not follow this either. So you're going to get into a little bit of a pickle if CMS doesn't change things, because CMS covers things at a 30 pack year. So they did take a while to change their coverage. Last time it took a couple of years. And so I would just advocate to watch for that too. The other thing to think of administratively and in terms of how we talk to our patients is just to try to figure out, like Dr. Berry commented on, is how do we form those clinical pathways that allow our doctors to confidently be able to talk to our patients about when they should have a screening and whether or not they are going to be covered or not. So that is a big challenge, as we all know. I love that that his physician had a sticky on their thing. I'm hoping that as a team and as a work group in the state of Maine, we can all kind of come together in how to help folks do this and get people comfortable with recommending screenings. Next slide. So I think what we can do also as a community is we can also advocate from our end on what we're seeing and try to help insurance companies and coverage from CMS and also coverage from the state of Maine, just to figure out how do we kind of get this manageable between all of us and also advocate for our patients. I think working on the oncology end, we see the patients when they're mostly at stage 4. I think every one of us that sees that cancer registry data, we can't deny that that happens. So I know everyone's very passionate about working together to try to make this as easy as possible for our primary care physicians to get patients screened and to us so that we can catch cancer at stage 1. So that is all I have. Very tricky as usual, but I know that especially for all of us, we can all come together and figure it out.
Terrific. Thank you, Barbara. Thank you, Dr. Berry. This wonderful presentations full of incredible information for all our attendees. At this point, we have this on a gallery view so we can have a few questions. And so we'll dive into those. We have one question so far, so I'll read this. This is for you, Dr. Berry. And the question is, if a patient smokes cigarillos, for example, black and mild, and meets the 20 pack year history with age criteria and is a current smoker or quit less than 15 years, are they eligible for lung cancer screening? People smoke cigarillos similar to cigarillos. I think maybe cigarillos similar to cigarettes, maybe. That's supposed to be underserved populations smoke more cigarillos, and it's a cancer disparity issue.
So the trials focused on cigarette smoking. It's impossible to say whether, as individual people were recruited to the trials, whether there were some cigarillo smokers, but the description is for eligibility was cigarettes, and that's what we have to focus our recommendation on. The recommendations are meant to be guidelines that clinicians need to apply with common sense. Whether that would lead to coverage issues, given definition of who smokes what, I'm not sure about. I will leave it to the clinicians to say whether they would fold that into a cigarette recommendation without telling you what to do myself. Barbara, any thoughts?
Yeah, I think that would be tricky. I think we'd have to look at, and what I would suggest looking at is how to calculate the pack years. I know, and I think Dr. Corson is nodding his head because I think that's come up with other topics in terms of, a cigar smoker versus other types of tobacco. If you smoke something that is not filtered or make your own cigarettes. So I think that would be the main focus in terms of making sure you're in compliance, is try to figure out how to calculate in pack years that type of smoking.
And I think I'll add that the pack year calculation can be a tough one for those who have tried to elicit that. What about people whose pack years have waxed and waned over the years? It's sort of the area under the pack year curves, and that can be a challenge. There's also some data to suggest that different people can smoke a cigarette more or less efficiently. So someone who lights it up and leaves it in the ashtray, common sense would say is going to be at lower risk for someone who really efficiently smokes down to the filter. And we don't have enough information to tailor to that recommendation, but smoking efficiency may be part of the story as well.
Yeah, and I see some folks are typing in, you know, there are those calculators, pack history calculators that can kind of help with those different things. Thank you, Catherine and Carrie.
Thank you so much. We have another question. Does the task force consider eliminating the years quit limit? There's data showing that one of the main reasons people who have been diagnosed with lung cancer don't qualify for screening is it's been more than 15 years since they quit.
Well, when I showed you the efficiency frontier, you could get some additional benefit by reducing that or lengthening the length of time beyond 15 years. As you remember from the curve, it begins to flatten out there, but I can't say there's no additional benefit. And the key question is where to stop. Again, we're engendering radiation exposure and additional harms as we do more and more scans. So we have to think about that trade-off there. Again, the randomized trials, and we try to stay as close as possible to the direct evidence of the randomized trials in making recommendations, use the 15-year quit threshold.
Great, thank you, Dr. Berry. And again, just encourage anyone to put your questions either in the Q&A or the chat. We're still doing well for time. Go ahead, Dr. Berry, want to say something?
Sure. One of the things, just reflecting on Barbara's talk, is that it will be a while before there's coverage for the 20-pack year folks. We're only screening about 15% of the people nationally who meet the old criteria. So we got plenty of work to do to identify those folks and get them screened before perhaps worrying too much about getting to the younger folks, even though screening them is important. So we shouldn't get discouraged. And we'll carry on.
Great, thank you very much. Just going to give a couple more minutes to see if we have any other questions from the group.
There's a couple of questions, Jessica, in the chat.
Oh, just came in, perfect. Yep, thank you. I had the question answer. So, okay, great. Thanks, Mary. So Medicare and some other private insurers only accept ICD codes that name nicotine-dependent cigarettes. So it's a potential coverage issue if it's other types of tobacco. So I don't know if either of you have a comment on that.
You know, again, it's back to the question of what variants of smoking exposure would be covered under the recommendation, and cigarettes, which I presume would be nicotine-dependent cigarettes. Now, are there nicotine-independent cigarettes? An interesting question. I don't know how much nicotine there is in cigarillos, going back to the prior comment, but you know, getting to the subtleties of coverage is a bit beyond the scope of the task force. I don't want to belittle how important that is in implementation of our recommendations. That the direct evidence deals with cigarettes, and that presumably is what the Medicaid, Medicare, and others are requiring in terms of a particular ICD code. So knowing what your local, and since those decisions are made by carriers state by state in terms of both Medicaid coverage and how the Medicare coverage is operationalized, it's important to understand what's going on locally in Maine and Massachusetts for us. I see Paul Hahn had a question there.
Yep.
That we may have skipped beyond. Hey, Paul. So I do think risk calculators may play a role. The trade-off, and I know folks at the NCI are working on risk calculators. And what I'd really like to see is implementation research that would suggest that, you know, my colleague who's got the simple recommendation based on age and pack years taped to her computer would actually go in to the computer and use a risk calculator to calculate risk, and whether the approach of using risk calculators could be done in an equitable way. So this would be applicable to our broad population. So I think so, but the implementation challenge here with only 15% of eligible people being screened is a real challenge.
Great. Thank you, Dr. Berry. Thank you, Dr. Hahn. I did see your question. I was going to go back. So thank you so much.
Sorry.
No, this is great. We're all looking at it together. So we have another comment here. There are SMD tools out there that say less than 15 years on Q. The USPSTF states once they have quit for 15 years, no longer eligible. Please clarify if the patient has quit 15 years ago, they are not eligible, correct? And then the person said, I meant SDM tools, shared decision making.
So I think I was also in on this chat. I think the question is the person who is at exactly 15 years since quitting. Is it a greater than or less than 15 years or less than or equal to, I think is the simple question.
So once they're screened, once you start screening, then it's it's if they're no longer eligible for treatment, then you would stop. And the recommendation was to continue screening beyond the 15 years quit. I will verify that actually while we're talking by looking at the recommendation. That's an important subtlety.
Right. Well, thank you.
Let's go on. I'll come back to that.
Sure. The next comment was, I am still not understanding why it may take, this may be for you. I am still not understanding why it may take longer than a year from a month from the date from private insurers. I thought it was only the grandfathered insurance plans that did not have to follow it for cost sharing costs.
No, that's a great question. So it's actually the way that the Accountable Care Act is written. It leaves that timeline for private insurances to make their changes. So I hear you. I wish it was right when it was kind of released, and if it was a better process, but the ACA did give that leeway. The other thing I'd advocate for is I wish that there was covering, all insurances, including CMS, because we run into that problem as we currently have, where CMS says that they'll stop coverage at 77, but the task force says 80. So for our primary care physicians currently, we have our workflow set up based on the task force, but then we have to figure out when the person turns 78 in the lung screening program, how do you talk to them, because they're not covered. So there's much better job that I think we can do with both aspects of that, but great question.
And I'll point out that as folks are aware, I think there are over 60 legal challenges to different facets of the Affordable Care Act, including the whole thing, including specific concerns about this linkage of covering professional services or covering the A and B services. So we've got to stay tuned because like other aspects of the Affordable Care Act, that may be threatened. Again, we as a task force don't make coverage recommendations, but certainly as a person and a clinician, people getting high value preventive services without worrying about out-of-pocket costs is certainly a really important part of the Affordable Care Act from my perspective as an individual, not a task force member. And I'm going to apologize. I actually went back to the recommendation, and we looked at this a couple of different ways in our models, but the recommendation is to actually discontinue screening once people are beyond the 15-year quit window. Now, I would say beyond 15, as we talk about exactly or not, but and again, those people, although their risk is lower than considerably lower than current smokers, are not at no risk. And the question is, how many CAT scans do you want to do?
Thank you very much. We're just at 1 minute of, so we have one more, maybe very quick question we can do quickly. Will the USPSTF be looking at research regarding cigarillos or cigars and lung cancer screening benefit in the future?
Well, we would certainly in our updates of our recommendations look at other forms of smoking. The challenge there is, of course, there'll never be a randomized trial with 15,000 or 50,000 cigarillo smokers. So, what we would probably do is look at the epidemiologic data regarding risk, but it may be a challenge to extend the recommendation simply on an epidemiologic argument. But we would look for evidence.
Great, thank you very much. Well, I think we're at time. So I just want to say on behalf of the Maine Lung Cancer Coalition, thank you so much, Dr. Barry and Barbara, for being our presenters today. Did a fantastic job, and it was a pleasure working with you for this presentation. We so appreciate the gift of your time with us today. I'd also like to thank all of you for joining us today, and again, sharing the gift of your time with us as well. In the chat box, you will see the link for the SurveyMonkey for CME. And again, don't hesitate to reach out to Mary Milam at mainmed.com with any questions or concerns getting your CMEs. So again, thank you all for joining us today, and we hope you have a wonderful rest of your day. Thank you.
And thanks for your help implementing.
Absolutely. Thank you so much.